Well, at the moment, I've been watching recent reports saying that the testing for allegedly COVID-19 is going to be more widespread now. So they're bringing out more tests. But what I'm not hearing enough about is the authenticity, how accurate those tests are, and whether they actually confirm that it is the COVID-19 strain of coronavirus as opposed to another virus. Well, it was estimated by one virologist, Dr. Wodarg, I think his name was, and he estimates that coronaviruses in general make up about 7 to 15% roughly of common viral infections annually. So that there's a whole range of different viral infections, and the coronavirus family, of which COVID 19 is just one strain of those. Or COVID SARS 2, as some people are referring it to, um, that family of viruses make up a certain percentage of all the other viruses anyway. So it's quite a critical question to examine whether you can distinguish by the testing that specific strain and what threat it therefore is, as opposed to distinguishing it from other viruses. Well, now, on that, there was a scientist called Kary Mullis, and Mr. or Dr. Mullis actually devised the testing that detects the viruses. And he said about the use of PCR, which is the method for testing for various viruses. And I'll quote Dr. Mullis: quantitative PCR is an oxymoron. PCR is intended to identify substances qualitatively, but by its very nature is unsuited for estimating numbers, that is the viral load. These tests cannot detect free infectious viruses at all. The tests can detect genetic sequences of viruses, but not viruses themselves. So that is a quote from Dr. Mullis, the inventor, as I understand it, of the PCR method of the testing. That would seem to suggest that you can't distinguish either the specific type of virus or the amount of the virus, what kind of role, therefore, that it is playing or contributing towards somebody's death or someone's illness. So I think there is a lot of concern about that when so many numbers are being reported. Well, if we look at the overall numbers, we don't know how many people have contracted COVID-19 because the testing is not complete. Not everybody's going to undergo testing, of course. There may be many people with milder symptoms that don't have it, the testing that is. And so we're never going to know the true number of people that have had it and recovered from it. But as more people are being tested and there's been more random samples of the population tested, we're seeing the estimated mortality rate coming down. And various studies now are estimating it to be between, as a mortality rate, 0.1 and 0.6, somewhere within that region. Some estimates, in fact, place it at lower than 0.1. And influenza itself is roughly a 0.1 mortality rate. So it may be slightly within that region. It may be a little higher or lower than influenza would be as a mortality rate. And we know that overwhelmingly the largest number of people that are said to be affected by it have other pre-existing serious health conditions that either contributed to their death or could have alone caused their death. So, and if we look at the numbers that are said to have died from COVID-19, in the UK, it's estimated now that over 20,000 have. But a certain number of those also mention other infections and pneumonia as well. How many of those are actually COVID-19 though? It's quite hard to know, given the fact that presumed deaths from COVID-19 can also be diagnosed as actual deaths, and given that we don't know specifically if the testing does confirm that exact strain as opposed to other potential infectious viruses. As I understand it from various reports that I've read from virologists, they seem to be suggesting that they test the antibodies within a person's biology. That is to say, the antibodies are produced in human biology in their body as a reaction to a viral infection. But antibodies themselves can be produced from a reaction to different infections, one would suppose. So whether there are specific tests that confirm an exact diagnosis of COVID-19 itself, or whether it actually is just testing to confirm the antibodies that could be a reaction to other infectious diseases, that seems to be quite a critical condition. Because if you look at the numbers reported in the UK, about 20,000 that are reported to have died. It may have increased from that number now. But in actual fact, in a typical year from influenza and other infectious diseases, that would not be an outlandish number. You might expect 20 to 30,000 in an average flu season. Certainly, just a few years ago, in a particularly bad epidemic of influenza, there were widespreadly reported up to 50,000 that had died. That was just in the UK. So, one wouldn't expect that to be out of proportion to a bad flu season. If it was that. If you look at it in a wider context, globally, they're reporting now up to 200,000 people have allegedly died of COVID-19. But there's many other countries, as well as the UK, that are allowing for reports of presumed cases of COVID-19 to be recorded as actual cases. That's the CDC in America's recommendation to doctors and healthcare providers. And that recommendation in the UK has now been extended to home care assistants without any medical training themselves, where they can make a diagnosis themselves, just from observing what the symptoms are and without any testing. Where, of course, the actual symptoms themselves are not unique and are not particular. They're quite general, and they can be quite similar to many other infectious diseases. This was reported by a virologist, a doctor of pathology, I think, recently, in his article for the Spectator, rather. He said it would be very hard to distinguish merely on observation what kind of infection it was causing something, just because the symptoms can be so similar between many different infections. So, given all of that we don't know specifically what the tests are actually confirming, and that some diagnoses are even happening without any tests at all, how can we be accurate for those numbers? Even if we accepted and we ignored all of that concern, if we accepted that 200,000 people have died as a result of COVID-19 globally, then that would still not be excessive in terms of the global number of influenza deaths. The average number of deaths through influenza globally is roughly estimated to be about 400,000. So we're at about half of that amount at the moment. And if that's an average season, you might expect that to be somewhere between, it could be more than that or less than that. That averages out. So it could be between, one might guess 150,000 to 250,000 or 450,000, or 500,000. That's just an average amount. 400,000 is an average number of influenza deaths. But actually deaths from pneumonia actually is much larger globally. Roughly 3 to 4 million people are reported to die globally of pneumonia. But there's a number of different infections that can actually cause pneumonia. If we look more generally at global deaths, cardiovascular is actually the largest reported number on the mortality list. Something like 18 million people were estimated to have died of the 60 to 70 million people globally that were estimated to die last year. That's a large percentage of those. That's little under a third of the total number of global deaths. So it's hard to sort of overestimate the number of deaths associated with cardiovascular, that is, heart disease problems. Quite worryingly, in the UK at the moment, some reports are suggesting that there's been a delay in response to call outs from people reporting chest problems and pains. So I don't know how accurate those reports are, but they are suggesting that some people are waiting up to several hours before emergency call-outs because they're being recognised as Category B and not as important as a COVID-19 call-out. And it's also been suggested by some healthcare professionals that maybe there are some people going through these heart problems, experiencing pain at home, who may be unwilling to go into hospital, who are not reporting the pains that they're going through until it gets to a later stage, because out of fear of contracting an infection in hospitals, because there's so much fear about that at the moment. So that itself, is a real concern. There's other healthcare professionals that have got concerns about the widespread cancellation of various appointments and checkups and various treatments, and what the result will be for those people with the long-term health conditions. So I really am not seeing at the moment enough discussion about how reliable these tests are that are being used to justify the measures of social isolationism and the social distancing policies in general. And of course, in a related issue, how or what effect are those social distancing policies having in particular on the most vulnerable at-risk groups, on those with long-term serious physical and mental health problems, especially those people that may be more isolated now through the measures and may be experiencing difficulty getting access to appointments, to treatments, maybe lacking support, and maybe feeling under a lot more stress with having the additional burden of not having that extra support from other people that they might have been dependent upon. All issues that are worth considering and investigating at the moment.